Hi everyone. This is um this is Daniel Fang here. I'm a child psychiatrist working here in Singapore, and I want to say good afternoon, good evening, and good morning to all our friends joining us from all around the world. We understand that about 900 people have signed up for this fifth World Infant, Child, and Adolescent Mental Health Day, or WICAM for short, webinar for 2026. Now, I'd like to remind everyone that this is an event that we have been organizing for the last 5 years, and the organizers, not in any order of merit or reason, but just for the sake that we've got the four organizations: International Association for Child and Adolescent Psychiatry and Allied Professions, IACPAP; the World Association for Infant Mental Health, WIAM; the International Society for Adolescent Psychiatry and Psychology, ISAP; and the World Psychiatric Association Section for Child and Adolescent Psychiatry, WPA, CAP. Um, today's webinar is to celebrate the World Infant, Child, Adolescent Mental Health Day. And this year's theme is emotional safety and preventing suicide. It really speaks to one of the most urgent responsibilities of our time, creating a world where every infant, child, and young person feels protected, connected, valued, and hopeful. Let's see if I can move the slides. Oh dear, doesn't seem to want to move. Okay, so this is this year's theme. On the right of your screen, or the left, I'm not sure, it's the right of my screen, you will see the logo that we created 5 years ago. And I think this logo is even more pertinent today as the world is thrown into all kinds of chaos, natural disasters, but more importantly, wars, and both from a physical war perspective, but also from trade perspectives. And it is so important that we remember this day for our next generation. Now, I just wanted to give you the program as a start. We have a short opening followed by two segments. Segment one is Building a Connected Ecosystem for Youth Emotional Safety by Dr. Christopher Chok, where he will talk about how we create a system, an ecosystem for supporting the young, both physically, but also importantly in this day and age, digitally. Then this follows a segment on the national guidelines for supporting suicidal youth by Professor Chidambaram Prakash from Australia, really to talk about the need for governance in this area. And also, we will have a global panel reflection, as well as a closing reflection at the end of this session. So, as I said, we've gathered at a time of great global challenges. Across many countries, we're seeing rising emotional distress, loneliness, anxiety, trauma exposure, as well as family stress, conflict, displacement, and the lasting after effects of the pandemic. In too many places, self-harm and suicide among young people have become painful signals of systems under strain. At the same time, the demand for care far exceeds the available workforce, funding, and specialist services. Yet challenge must not lead to despair. It must lead to wisdom. No country has unlimited resources. Most countries do not even have enough. So the question before us is not simply how much we have, but how well we use what we have. Emotional safety cannot depend only on hospitals or specialists. It must be built in homes, schools, communities, digital spaces, and primary care settings. Prevention cannot begin at the crisis point. It must begin early, relationally, and upstream. This means using limited resources intelligently, training parents and teachers, empowering community workers, and strengthening school supports using digital tools responsibly, integrating mental health into general health systems, and reserving specialist expertise for those with the highest needs. It means moving from scarcity thinking to stewardship thinking. So for infants, emotional safety begins with secure attachment and responsive caregiving. For children, it grows through belonging and trusted adults. For adolescents, it depends on dignity, identity, connection, and access to help without stigma. Across all ages, hope is a protective factor. Today's webinar brings together global voices, shared learning, practical ideas. Some solutions will be high-tech, others deeply human. Some will come from wealthy nations, others from countries that have learned innovation through necessity. We have much to teach one another. Let us use this time not only to discuss problems, but to build pathways, not only to count risks, but to cultivate resilience, not only to prevent death, but to promote life. Thank you for joining us, and thank you for your commitment to the mental health of the world's youngest citizens. So, sorry. So for our first segment, I'm going to ask Dr. Christopher Chok from Singapore to share his model that we have built here in Singapore of a connected ecosystem for youth emotional safety. Over to you, Chris. Oh, are we having some technical difficulties? But we can start with the second segment.
Okay.
Perhaps, Paul, you could introduce Professor Prakash.
Okay, yes, that'll be good. It'll be me a great honour to do that. Hello, everyone from all corners of the world, some 900 or more of you joining us. It's a real pleasure to be sharing our commitment to infant, child and adolescent mental health care. And it's a great pleasure for me to introduce my boss, Dr. Chidambaram Prakash. As I'm doing so, I've taken the opportunity to talk a little bit about infants and preschoolers since I'm past president of the World Association for Infant Mental Health and have a great commitment to how we can intervene very early in understanding and minimising the impact of mental ill health on infants and young children. As we traditionally do in Australia, I'd like to acknowledge that I'm on the lands of the Wurundjeri people of the Kulin Nation, Aboriginal Australians who've been custodians of this land, Australia, for some 60,000 years. And I'd like to pay my respects to elders, past, present and emerging, and warmly welcome any Aboriginal colleagues and First Nation colleagues from around the world who are with us today. I acknowledge people with lived experience of trauma and mental ill health and recovery, and the experience of persons who are their supporters and carers, and acknowledge the importance and respect for all communities and peoples in the world, especially in these current times that are very, very stressful for so many people around the globe. Yeah, so we're trying to explore this question of how do we develop emotional safety, prevent suicide in this post-pandemic world and in this world that's full of conflict. I'd like to sort of introduce the idea of infants and preschoolers as people with their own set of mental health problems, which are overlooked very often by funders and planners, forgotten for identification, treatment or preventative care. I guess it raises the question, how could a baby have a mental health problem? Well, we think that from birth, the baby is discovering who they are, and their discovery is dependent upon the carers that they have. The parents help the baby achieve their potential through helping the baby know who they are, help them understand their own thoughts, feelings, intentions, wishes and desires. The absence of this care from primary carers represents a trauma in itself. So I think it's very much incumbent upon us to try and prevent later mental health disorders. Did I turn off the PowerPoint or no? Okay, keep going.
Fine. Yeah, keep going.
And it's important for us to think about mental health promotion and prevention in relation to infants. Important for mental health services to reach out to primary healthcare providers, welfare providers, educationalists and carers, as well as parents, and particularly to work with parents with lived experience of mental ill health. There are a number of movements around the world emphasising this first 1,001 days, the first 3 years, 2 years of life, the pregnancy. All of these are critical times in the development and setting a foundation for a healthy mental health experience for the child. It's where advocacy comes in, and we encourage all of our colleagues to be strong advocates. I've just listed at the bottom there a couple of key foundations in the UK, but in every country there are now organisations out there advocating for the mental health of infants and young children. Why? Because infants and young children experience mental health problems. This is just a snapshot of a couple of surveys of mental health problems amongst infants. And you'll see, even in Norway, with their very high level care of mental health and general health for children, there's a prevalence of formally diagnosable mental health problems in the 4-year-old population. Larger in a number of states in the US. One of the tools that we've used is called the BITSIA, which is a brief infant toddler social emotional assessment. And with that one, some 10.4% of 12 to 36-month-old infants were in of concern range. They were diagnosable social, emotional, developmental or behavioural problems. And these problems continued through into school age. So there's jobs for us. There's ways of really collecting a vision of the child who's particularly at risk. And one of the tools that has been used is the concept of adverse childhood experiences. This is just one of many studies that have been looking at that in very early age, but a really very innovative one from Sherry Madigan and her colleagues in Alberta, where they've worked with families where adverse childhood experiences are present, trauma, death of loved ones, witnessing violence, serious illness, and a range of other major trauma. And the group in Alberta have examined the histories of some 1,000 or so, 2,000 actually, participants, mother-child dyads from pregnancy, and then followed them through to 8 years. And found that there's a high level of behavioural concerns and difficulties for children when they reach the 8-year mark, and by implication further on. What they've done is taken this a step further and tried with parents to design an intervention, and an online intervention that's accessible, compassionate, non-judgmental, and it's got practical suggestions for parents to try and avoid, as they say. I don't want my child to have the same experiences as me. I had a traumatic child. My parents argued. My grandmother died. I was very disorganised and distressed by it all. I don't want the same for my children. So ACE's hub is a resource that Sherry Madigan and colleagues have established. It's available free and online, courtesy of the Canadian government. And they've also developed these online resources for families on an organisational thing called COPE. In Denmark, going back to Skovgaard and her colleagues, they've commenced a really innovative intervention starting very early in the first months of life, and following these children through to 3 years of age, using clinical interventions that are able to be scaled up, video feedback, positive parenting interventions, using a tool to look at infant withdrawal and depression, the ADBB, and the newborn behaviour observation to build that infant-parent relationship. There's a lot of other interventions that have got a strong evidence base, and this paper from Peter Fonagy's group, Michelle Sleed at University College London, has listed 68 discrete studies. That's a few years ago now, so there are more since then, that have got a good evidence base and are doable, and some able to be rolled out in larger scale. So there is a point in identifying and working with infants, very young children at risk, and it's incumbent on us to do that. No such thing as a baby, said Winnicott provocatively, but with intent. He emphasised the importance of seeing the infant, the very young child, as part of the family, and our interventions must be to work with the infant within the family. It's been a pleasure to be able to take that bit of time just to emphasise the infant. But now I'm really pleased to introduce Dr. Chidambaram Prakash, who's the director of the service where I work at the Royal Children's Hospital in Melbourne. He's a child and adolescent psychiatrist with some 25 years experience, just a young man who's made a huge mark in the work of the mental health service at the Children's Hospital and throughout our state here of Victoria. He's got a special interest in neurodevelopmental disorders, neuropsychiatry, and acute consultation liaison psychiatry. Prakash is working with the kids who have the greatest need, the greatest level of trouble. He's leading reform in the mental health service to modernise risk management systems and extend risk assessments beyond suicide, self-harm and aggression to include developmental risk and psychosocial risk. And I'm sure this is going to have wide-reaching impact on mental health and behavioural risk assessments and clinical practices across the hospital and through our state. So it's my pleasure to hand over the battle to my friend and colleague, Dr. Prakash.
Thank you very much, Campbell. Hopefully you can see my slides. It is a great pleasure to be here, and I would firstly like to acknowledge my senior colleague, Associate Professor Campbell Paul, who invited me to talk with all of you. It's a great pleasure to speak to all of our colleagues from around the world. I too would like to begin by acknowledging and expressing my gratitude to the traditional owners of all of the lands that we are meeting today from around the world. I would like to pay my respects to their elders, past, present, and emerging. I would also like to acknowledge the children and young people with lived and living experiences of mental ill health, neurodevelopmental disorders, the psychological consequences of medical illnesses, and the mental health consequences of substance misuse. I would also like to acknowledge their families, carers, and professionals who work with them. And along with that, acknowledge all our First Nation colleagues from around the world. Today, I will be presenting on two topics. One is on the evidence-based guidelines, clinical practice guidelines that we have created for the management of suicide and self-harm in children and adolescents here in Australia, and a program that we have started in our own mental health service called SAFER, which is an evidence-driven modernization of the management of mental health risks in an infant, child, and a youth area mental health service. Firstly, the guidelines, and with acknowledgement to all my colleagues from across different disciplines, services, professions, including lived experience staff who were very much a part of developing this guideline. We deliberately decided in the Melbourne Children's Campus Mental Health Strategy, which includes the Royal Children's Hospital, Murdoch's Children's Research Institute, and the University of Melbourne, Department of Pediatrics. We decided to create these guidelines to be broadly based, to not just focus on the specialist mental health professionals, to include non-health professionals, general practitioners, allied healthcare professionals, mental health professionals at primary and secondary levels, educators, youth workers, community staff. And it focuses on the management of suicide and self-harm in children and adolescents up to 19 years, focuses on suicidal ideation and suicide attempts and non-suicidal self-injury. The guideline itself has 71 recommendations. 7 of them are evidence-based recommendations, and the other 64 are consensus-based recommendations. This itself shows that the importance of reflections from expert opinions, the evidence from clinical realities of practice from day-to-day life being quite important. The actual number of studies are relatively less in this area, but there's a wealth of knowledge from practical experience and lived experience as well. Importantly, this is Australia's first pediatric specific clinical practice guideline on this topic. So we start with just understanding the terms used in the guideline. So suicide refers to the intentional act to end one's life, resulting in death. Suicide attempt has the same intent to die as suicide, but the person survives. Suicidal ideation are thoughts of wanting to end one's life, which can be passive, such as a sense of meaninglessness, to active preoccupation with death. Non-suicidal self-injury is intentional self-harm without the intent to die, which could be a range of different things like cutting, burning, and all of that, and can co-occur with suicidal ideation and increase the risk of suicidal ideation and suicides later on. The youth suicide picture in Australia, unfortunately, is worsening for us here, and it is something that we are really grappling with year after year, particularly worse since the pandemic. We've seen the youth suicide becoming the leading cause of death for young Australians 15 to 24 years. And since 2020, which is the peak of the pandemic, in the middle of 2020, emergency department presentations for deliberate self-harm, suicidal ideation, non-suicidal self-injury have more than doubled in the young people. There are also significant inequities with this as well, that 21% of deaths among First Nations young people 5 to 17 years are due to suicide, compared with 16% amongst the non-Indigenous peers. We're also seeing a sharp increase in greater hospital presentations of young people with non-suicidal self-injury, particularly in the 10 to 14 years group, which we did not see pre-pandemic. So that's something new. Our predominant population in the emergency departments was 15 years and older, whereas that age has gone down to 10 to 14 years, which is quite alarming in itself. These data highlight why coordinative, preventative, evidence-based action is urgently required across all the systems that influence young people and, in fact, children as well. The guideline was developed by a multidisciplinary team that included a psychiatrist, a few psychologists, general practitioners, nurses from both mental health and acute health, social workers, researchers. There were 5 lived experience advisors as part of the core guideline developmental group. They were not just consulting, but they were actually meeting with us throughout the whole co-design process. The group involved people in private practice, general practitioners across different states within Australia, and professionals working within the Royal Children's Hospital, Murdoch's Children's Research Institute, and the University of Melbourne, who were in partnership in this. It took 18 months of development and included evidence review, subgroup meetings to arrive at consensus, and then the drafting process. There was public consultation between October and November 2025, and then it was eventually accepted by the Royal Australasian College of General Practitioners as a clinical resource, which we are extremely grateful to them for. The young people with lived and living experiences shaped every section. There were a number of things where we were challenged in terms of the language we used, the assumptions we made about the care we were delivering. So it was a very humbling and a big learning experience for those of us professionals who were involved in it. There were artwork and quotations and lived experience reflections embedded throughout the guidelines. The guideline framework itself, as I said, was 71 recommendations, of which 7 were evidence-based and 64 consensus-based. And it's certainly, we're glad to say that this has been an extremely privileging and humbling learning experience for certainly myself, but also I think that is something the other colleagues would share as well. In terms of the principles of care, it covers several things. The first thing is it focuses on making pathways to care for children and young people with suicide and self-harm accessible. And it states declares that community schools and clinical settings must have clear pathways to recognize and seek help. This is in keeping with a very important Royal Commission that was constituted by the government of the state of Victoria, the state that Melbourne is in, and where Campbell and I work and live. This Royal Commission that ran over a few years gathered a lot of evidence through public consultations and literature reviews. And one of the important recommendations it made was to increase access and improve services for people across all age group, but particularly children and adolescents with suicide and self-harm. The second thing that the guideline stresses is person-centered care. The decision should involve the child and adolescent and their support systems. They must be culturally safe and trauma-informed. There must be clear communication about how the assessments are completed. So the assessment process should be explained to the child or young person in the language and in the way that they understand. And then the questions must be specific and unambiguous when looking for the symptoms of suicidal ideation or non-suicidal self-injury. The guideline also stipulates that healthcare professionals must undergo appropriate training, registration and supervision. So it's not just the training and the registration, but ongoing supervision when they see children and young people who are suicidal, because that can obviously have an impact on the professionals as well. And we all know the impact of vicarious trauma on service delivery and engagement with children and families. The guideline very clearly says that all types of aversive, punitive, restrictive approaches must be avoided, and reinforces the importance of minimizing restrictive interventions based on our own, and I'm sure various international mental health legislations as well. In terms of identification and risk assessment, it talks about various sort of evidence-based risk factors that have to be focused on, like previous suicide attempt, personal history of mental illness, neurodivergence, family history of mental illness, peer suicide attempt, maltreatment or abuse, bullying or cyberbullying, contact with child protection services, and out-of-home care, which is quite an important focus of care. In our state of Victoria, we have sort of acute access and early access pathways for children living in out-of-home care. Some other consideration that it has sort of identified is the importance of increasing social media awareness of suicide and self-harm, keeping in mind that there is increased social media use and the harmful experiences that children have online. The importance of addressing social isolation, the importance of identifying in the assessment adverse childhood experiences and incorporating that into the risk formulation and the thinking around the interventions, financial stress and family legal difficulties, deaths and bereavement, community or family violence, discrimination and racism. The guideline also explicitly states, I guess, what we have all known for a very, very long time, that the person's identity, whether that is a First Nations identity or the identity of being a refugee or from a different culture to the country they live in, or having a particular sexual preferences, LGBTQIA plus gender preferences, they themselves do not lead to an increase in suicidal ideation or suicidality, but it is the exclusion, the stigma, the discrimination, the systemic inequity that lead to the increase in risk of suicide and self-harm. So the importance of identifying young people and children to provide care that is tailored to their needs was stressed. It made some recommendations in terms of care in non-mental health settings, because we see a very large number of children, young people, and their families go seeking help for mental health problems, in particular suicide and self-harm, to non-specialist healthcare professionals, non-mental health care settings, such as GP clinics or pediatrics clinics or primary healthcare setups or clinics. So it was important that that the guideline also addressed some of the the matters concerning providing care in non-mental health settings. So one of the things that it talks about is that many young people first present in schools, community settings, or general practice. Non-health professionals are not expected to conduct a comprehensive mental health assessment. Their role is to ensure the immediate safety of the young person, assess distress, and refer promptly to specialist mental health facilities. And so they must have the contact details and the awareness of how quickly the children and young people can be seen by the specialist mental health services in the local area. But they may also have training, and we certainly have started a program at RCH Mental Health where we provide community of practice training sessions to GPs and pediatricians on a range of mental health topics, with a big emphasis on mood and anxiety disorders and suicide and self-harm. As part of that, the importance of creating a safety plan when children and young people come into contact with health professionals, and that safety plan being shared with other key health professionals in the life of the child or young person so that they can follow the safety plan as well. The importance of training GPs to conduct a biopsychosocial assessment and a basic risk assessment and a co-constructed safety plan, which we cover in our syllabus of training for GPs and pediatricians. The importance of providing information on safety planning and harm minimization and coping strategies. The importance as part of the history and the evaluation in a GP clinic or a pediatric clinic is to talk about the home environment, social and family supports, past history of non-suicidal self-injury, and also care for any co-occurring conditions, whether that is substance use or physical health problems or chronic pain, and all of these things, which often are known factors to increase suicidality and self-harm. The guideline talked about the standard of care that should be provided in an emergency department or urgent care settings. In particular, it said things like that emergency departments must have a private space where they see children and young people who present with suicide and self-harm. The space must cater also for children and young people who are neurodiverse, reducing the noise and the stimulation there. The waiting areas that these children and teenagers are expected to be in emergency departments needs to also be kept separate from the acute busy medical environment. The guideline also insists or stresses that both medical and mental health care need to be provided concurrently, so that they're given equal status of importance, but also that we have noticed that often what happens in emergency departments is that children, young people wait for several hours, sometimes in a busy ED during the peak seasons. For us in Melbourne, it's winter time when it's peak season. They often have to wait to be triaged first. And there's a common triaging process for all people presenting with all types of problems, including mental health problems. And then they have a physical evaluation. Then eventually they are referred to a mental health professional. Now, this delays care. And by the time decisions are made with regards to mental health care and admissions and things, the child or the young person is often tired. They are fed up. They're sick of waiting. They don't wish to really engage. So to avoid all of that, a mental health professional should be in attendance in the ED, not liaise remotely, and care needs to be provided concurrently. The assessment itself should involve a biopsychosocial assessment and include an evaluation of the safety features at home and discussions about harm minimization and all of that. The length of stay in the emergency department should be kept as short as possible, except if we are catering to their neurodiversity, or we are trying to organize admissions, or we are putting together a safety plan to discharge them home. But even then, the idea should be that the young person and the child should be kept as brief as possible in the emergency department. Consideration in terms of particular cultural factors and religion and beliefs within the family must also be taken into account, even in an emergency setting. In terms of specialist mental health settings, the guideline is quite explicit about some of the things that we have known recently, which is that there must be a thorough biopsychosocial assessment. whilst the physical injury is being addressed as well. The assessment itself should be conducted in a quiet, private space where the young person can speak with confidence and their confidentiality is maintained. The evaluation must include questions about social life, peer relationships, home environment, social media use, safety concern, historic and current factors, risk factors and protective factors. Explore the function and the motivation of the non-suicidal self-injury or suicide attempt. Make reasonable adaptations to neurodevelopmental conditions, language, using iPads, using various other tools for communication. Building the importance of building a therapeutic relationship and involving support people and trusted professionals in the life of the young person, and carefully also question the relationship with the parents and involve the parents when it's appropriate to do so. The importance of building rapport. And finally, the evaluation itself must move away from the risk assessment tools that result in a low, moderate, high categorization of risk, and instead use a risk formulation amongst the various types that are now that people are often trained in doing. We certainly are training our staff in various forms of suicide risk assessments and risk formulations, which I'll talk about in a minute. In terms of the aftercare and safety planning, it must contain the safety planning must contain identified triggers and warning signs of increased distress, appropriate coping strategies and the barriers to using them, the support people who can help resolve a crisis, the contact details for healthcare services and emergency contacts, the established means of self-harm and the steps to restrict access to those means, steps to make the environment psychologically and physically safe. The safety plans must be developed collaboratively and accessible in digital or visual formats. We did a research study recently amongst inpatients in our adolescent mental health unit, and we found that 80% or 85% of them said that they did not use their safety plans when they were made on paper. And so they took them home and left them somewhere, and they did not know where it was. And more than 50% of the parents also said that. So having that digitized in some way and being made available in a phone app with some kind of ability to kind of trigger a warning sound or something when the young person access it is kind of important. So we've kind of looked at that, and there are multiple safety plans and phone apps that are now available, which can be downloaded. But that's something that is increasing with AI kind of involvement in that as well. In terms of treatment recommendations, the guideline explicitly says that pharmacological treatment should not be offered as first line, specifically for non-suicidal self-injury and suicidal ideation. But psychological intervention should be offered without delay, regardless of age, diagnosis, substance use, status, or co-occurring conditions. It very much says that dialectical behavior therapy tailored for children and adolescents is useful for non-suicidal self-injury and deliberate self-harm, but other CBT-based approaches tailored to a suicidality prevention may be considered where it's developmentally appropriate. Harm minimization is quite an important thing, and the conversations around harm minimization are also quite important. In terms of when to admit to hospital and when to kind of manage in the community, the guideline quite explicitly says that management must be in the least restrictive environment, which is in keeping with the mental health legislation in our state, but I'm sure it's the same case all over the world. And an admission to a non-mental health ward must only be considered when there is clear clinical justification, including if there is it's kind of a medical problem. So, for example, if the person has taken an overdose or made a serious self-harm attempt that needs medical treatment, then they should be admitted to a medical ward. Otherwise, the admission should predominantly be to a mental health ward with the appropriate services and professionals available to provide the care that is required. The admission must always have specific goals, must be kept as brief as possible in order to return the child or the young person to the community to continue with therapy. Because hospitalization can be quite distressing and can lead to an increase in feelings of distress in the child or the young person during the admission. And so all care needs to be taken to provide maximal supports, and the supports must then extend into the community as well, including sharing the safety plan with people in the community. Young people admitted to inpatient units must have access to mental health nurses and psychiatrists and psychologists and a multidisciplinary team. And if beds are not available in adolescent wards, sometimes in various states in Australia, we do admit young people over the age of 16 years briefly to an adult ward if the safety of the young person is at very serious risk at that point and they need to be kept safe, then we do admit young people into an adult ward. But that sort of admission must be kept as brief as possible. And if the young person needs ongoing inpatient care, then they should be transferred to an age-appropriate inpatient facility. And before discharge, a safety plan must be completed, referrals must be made, an outpatient appointment must be firmed up. All of those things need to happen. And it is recognized that hospitals are sometimes useful, or often useful, to stabilize the risk. But that does not mean that the risk is completely resolved. So ongoing outpatient care is very important. And within that, I think it is also important to involve people that the young people trust, which may be their guardians or which may be their support people. And we have in Victoria, in the legislation here, the provision to have a nominated support person who may not necessarily be the legal guardian, but it could be someone else that the young person chooses. In terms of prescribing, there are some sort of guidelines, advice given on safe prescribing considerations, that pharmacological treatment should not be offered as first line. When prescribing for co-occurring conditions, we must consider the risk of adverse effects, which might increase suicidality, which is prescribing SSRIs for depression, and the risk of increasing suicidal ideation, potential toxicity and overdose and drug interactions. Particular caution must be exercised with opiate-containing painkillers, tricyclic antidepressants, propranolol, all carrying high overdose lethality risk. A medication review must be conducted with every time the child or the young person is seen. And when multiple prescribers are involved, ensure that there is clear communication. There is only one prescriber. The others providing advice is okay, but there is only one prescriber, so that it's clear how the medication is being used, who's prescribing, how much is being prescribed, and all of that. Discuss with the young person and family the importance of safe storage of the medication, the adverse effects, limit the quantity supplied through talking with the pharmacy. They are able to do that. In Australia, they provide Webster packs, which contain a limited amount of the medication. And sometimes we even say that the person has to return to the pharmacy weekly or twice or 2 weekly to get the supplies of medications. GPs and pharmacists can also use the consultations as a means of inquiring about side effects of the medication, and sometimes even ask about self-harm thoughts and suicidal ideas, and can then contact acute services if need be to link the child or the teenager back into the acute services. In terms of First Nations and diverse populations, care needs to be taken to ensure that certainly in our state, it is part of the legislation and part of the rule that when we have a First Nations young person admitted to hospital, that they are given access to appropriate cultural support from First Nations background people. And similarly, structural inequities and stigma associated with LGBTQIA plus gender diverse groups must be sort of addressed as well. Culturally, linguistically diverse children and families must have access to translators or interpreters and culturally safe, person-centered care. And neurodiverse young people must have adaptations made in the communication for the assessment, the engagement, and all those things. I will talk briefly now about the SAFER project in the mental health service that I work in. We commenced this in 2022, and primarily what we have done is that we are systematically removing the rating scales that we use to assess children and young people that result in categorical labels of low, medium, high, and instead replacing them with a risk formulation. We have chosen the Pisani risk formulation created by Anthony Pisani after meeting with him several times. During the course of our meetings, the Pisani formulation itself was sort of adapted for aggression. Now we have actually taken it and expanded on it, and we have adapted it for family risks and psychosocial risks and developmental risks so that it is appropriate to be used from infancy through to 18 years. So the risk formulation considers long-term status, the dynamic state, strengths and available resources, precipitants, forthcoming escalations in risk. And following that, we've developed a tool called the Risk Assessment and Formulation Tool, which is now being built into our electronic medical record. So we use Epic EMR at our hospital, and it's being built into that. And along with that, there is a 7-stage safety plan, which is an adaptation, a kind of age-appropriate and stage-appropriate adaptation of the Stanley Brown 7-stage safety plan. So we're kind of using graphics and pictures for the young children and other things. And training all staff, including non-clinical staff, on recognizing distress in children and young people who come into the waiting room and sit there, and certainly training the clinical staff on risk assessments and doing risk formulations. So these are some contact services, contacts for young people who may be in crisis. Lifeline, Beyond Blue, Kids Helpline. These are all services that are available here in Australia. I'll finish off with this quote from one of our lived experience advisors. May you be one of the many outstretched hands ready and waiting to walk alongside folks as they reach out. So it really clearly says that what we have to do is to kind of accept our human nature of being imperfect and take the opportunity where we see infants and children and young people as a privilege and walk their journey with them, alongside them. And that is probably the best way to help them. And that is also the best way that we gain clinical experience and expertise. So with that, I will conclude my talk, and thank you very much for this opportunity.
Thank you, Professor Prakash. And I hope to be able to get this right now. And can you all see? I hope you can all see, right? Okay, thank you.
Looks good.
Yeah, thank you. So we've come back to, I suppose sometimes it is good to have the back end before the front, but segment 1 is now going to be presented by Dr. Chris Chalk, and I hope that my thing will make it work. I get an opportunity to introduce Chris. Chris is an old colleague of mine. He is now currently in a new position of being the Assistant Chairman Medical Board for Digital Health, the Senior Consultant and Chief of the National Addictions Management Service, and the Director of our National Mindline 1771, which is a national crisis helpline for all age groups, including children. So, Chris, over to you.
Welcome for the audience. Thanks for joining us for this presentation on how Singapore builds a connected ecosystem for youth emotional safety. My name is Chris, and I'm speaking from Singapore. And I apologize that I cannot be there in person to give this presentation. Today, what I'll attempt to do is to describe Singapore's journey in building our digital capabilities to meet the needs of distressed youth. A little bit about Singapore. Singapore is a very small country. You can go from one end of the country to the other end of the country in 40 minutes, driving about 50 kilometers. We have a total of about 6 million population, of which 3.6 million are citizens, and the rest are expatriate staff working in Singapore. We have Chinese, Malays, Indians, and a mix of other races in Singapore, and we are truly a multi-racial society. We are also a rapidly aging society with 19% above the age of 65. And like many industrialized nations, we are struggling with a low birth rate, with a low total fertility rate, and we are not currently at replacement level. We are a high GDP per capita economy, and the main structure of economy are in services, professional services, manufacturing, and our port activities, both the seaport as well as the airport. We are also a leading financial hub, not just for Asia, but also the world. I come from the Institute of Mental Health, which is the only psychiatric hospital in Singapore. We have about 1,700 inpatient beds, and we perform about 400 outpatient consultations a day. We are also a teaching hospital, and we teach students from 3 undergraduate medical schools in Singapore. IMH has a full spectrum of clinical services, including emergency services, child and adult services, forensic addictions, and we treat virtually every psychiatric disorder at our hospital except serious eating disorders, which we partner with a general hospital. What is the problem that digital mental health hopes to solve, or at least mitigate? Everyone knows the current global situation. 1 in 7 youth aged 10 to 19 have experienced a mental disorder. And there is a prevalence of almost 15% of mental disorders amongst adolescents internationally. Singapore has done multiple surveys to try to establish the prevalence of psychiatric disorders in our population. And our studies show that we are just like many other industrialized nations, and major depressive disorder is the #1 psychiatric disorder at 6.3%, alcohol abuse at about 4%, OCD at about 3%, anxiety, GAD at about 1.6%, as well as bipolar disorders. Generally, the vast majority of people with psychiatric disorder do not wish to seek help, and this is an area of concern for us. But when they do seek help, many of them would prefer to go to a counselor or a psychologist or a general practitioner. And for many, only when they don't have to do they access medical psychiatric care. Currently, we have about 4.6 psychiatrists per 100,000 population, which is considered quite low for OECD country. The highest risk really is for psychiatric disorder is actually in the young group. And 3 successive national surveys have found that the young as well, the teenager as well as the young working adult, a quarter of these people have expressed that they have very bad mental health. And this is something of concern to all of us in Singapore. Singapore has a tiered mental health system, and we tiered our patients into 4 tiers. At tier 1, they are mentally well, and we try to prevent psychiatric illness. At tier 2, they are at risk, resulting from some distress or some psychosocial problems that they have, and we will channel them to low-intensity services. At tier 3, they begin to have a psychiatric disorder, and they can be separated to mild and moderate cases. These are typically tiered to counseling services or general practitioners. And at tier 4, these people require hospital-based specialist psychiatric care. How we tier our patients, we use the international WHO system using PHQ-9 as well as GAD-7. And on the screen, you will see the typical thresholds and scores that will qualify a person into that particular tier. In the National Youth Mental Health Survey done in 2022, they found that actually psychiatric distress was had quite high prevalence in our society. They said that 12.9% of youth in Singapore reported severe to extreme severe levels of stress. They felt irritable, they felt upset, and they felt they were unable to relax. From the risk factors for mental health issues include having a high social media access and use more than 3 hours a day, having been cyberbullied, that they are smoking or vaping currently, they have multiple adverse childhood experiences, or they have negative body images. And protective factors included good social support, self-esteem, as well as personal resilience. So what is the problem that digital mental health is trying to solve? Firstly, the high prevalence of mental disorder in the community. Secondly, we are trying to increase access to care because studies have repeatedly shown that the majority do not seek professional help. Even when they do come for help in the clinic, our clinics are very busy. And we have roughly a 2-month waiting period from the time we receive a referral from a general practitioner to when a first visit appointment is available. And we also want to be able to provide care in multiple settings that need psychiatric help, including nursing homes as well as the prison. I'd like to show you now a simple video that describes our mental health capabilities.
How do we help when 1 in 4 young adults in Singapore report very poor mental health? Digital mental health is the force multiplier to meet this demand for mental health services. At a population level, when a person is not ready to see a professional, Mindline.sg provides self-help and wayfinding tools to find help. Let's Talk provides an anonymous way to ask a question on a mental health issue and a psychologist will reply. If they want to reach out to a professional, National Mindline 1771 provides free 24/7 phone and messaging support. While waiting to see a psychiatrist, MDTX can provide mental health interventions during the 2-month waiting period. In between psychiatric consultations, Hope's app provides a digital companion with mood logging, self-help, and journaling tools. Telehealth and internet-delivered cognitive behavioral therapy gives the option of patients to seek help in the privacy of their homes. To meet the demand for mental health services, digital mental health is the solution. Digital mental health is here for every step of the mental health recovery journey.
So this schematic shows the digital mental health ecosystem in Singapore. The backbone of our digital mental health efforts is our e-health infrastructure. We have digital ID in Singapore in the form of SingPass, which is a digital ID that's found on our mobile phones that gives us access to all government services. We have Health Hub that allows for us to make appointments in hospitals, to make payments, as well as view our lab results. This is available to all citizens. Our National Electronic Medical Records is based on EPIC, and we also have a single national electronic health record for all citizens, such that when they move from one clinic to another clinic, doctors are able to see their medication lab results and all their encounters with other clinics other public health clinics in Singapore. We use Gen AI LLM in the form of PAIR, which is based on Claude, and these are assistants to clinicians. And we also have a community health referral system so that we can flow patients from the hospital into nursing homes and counseling centers in the community. That is the backbone of our digital services. And we aim to have a digital service at every tier of our mental health system. At tier 1, when the patient is well, we have MindSG, which is a preventive service from the Health Promotion Board. In MindSG, you find good quality information on how to promote mental health, how to sustain good mental health, and where to seek help if someone needs to find a service. When they go to tier 2, when they are slightly mildly distressed, we have self-help systems in the form of Mindline.sg and Let's Talk. Let's Talk is a peer support forum in which a person can post questions about mental health issue and the psychologist will reply them anonymously. If a person feels ready to talk to someone or to message somebody, we have National Mindline 1771, which is our national mental health call center. In the past 7 months, since National Mindline has been launched, we have served over 40,000 users in Singapore. We are currently doing a trial on a community-based eCBT service in the community when a GP refers to a community counseling center. And once the patient is referred to a hospital like IMH, we are currently running a randomized control trial as to whether AMDTX, a mental health app, can help reduce psychiatric distress during the wait period of around 2 months. Once they enter our care, we have 3 digital services for the patient. One is an eCBT service. The second is the HOPES app, which is a digital phenotyping and remote monitoring app. Patients are given a Fitbit watch, and HOPES is able to integrate into the watch with the watch and send data back to the hospital on the patient's well-being. We also have a very well-developed telehealth service whereby we provide telehealth services into many nursing homes, the prisons, the courts, and other settings. What is the issue that young people face? For a young person who may be a teenager and not knowing national services well, they may not know where to go for help. They may not understand that what they are going through may be a psychiatric disorder. They may feel that the symptoms that they're experiencing can be managed on their own. And they're also afraid, what if my parents find out that I have this problem? And they may not feel that adults are ready to help them or feel comfortable talking about their problems with an adult. And that's why our services are primarily designed to be anonymous in nature so that we can reach out to the young population who may otherwise not want to contact anybody. So if you have a 15-year-old who is struggling, where does he go first? Let me bring you through our Singapore mental health ecosystem. Meet Alex, he's 15. He feels lonely after COVID. He can't sleep at night. He's doom scrolling in bed. And he thinks, what's the point of all of this? When he's up at 11 p.m., there's no school, there are no clinics open, parents are not available or sleeping. So Alex may go online to Google his questions about his mental health issues. So Alex's first stop may not be a clinic because there's not a clinic available at that time. We have the chat service, which is specially designed for youth in Singapore. The chat can be reached by a web chat system, which is also anonymous in nature. Through chat, they can be referred to a school counselor, and finally, the student can be linked up to a professional in his school, and this may be the opening to connect him to talk about his issue with his parents. If Alex doesn't want to access a counselor, he can access Youth Mindline, which is available on mindline.sg. Within Youth Mindline, we have self-help resources. We have materials to short CBT exercises, as well as a wayfinder and self-assessments. And we can guide them as to how to find help within Singapore. Another service is Let's Talk, whereby Alex can ask a therapist anonymously on a particular mental health questions. There is also a self-care lounge, as well as we host community events whereby we invite people to come together for social support. Let's Talk receives about 30 to 40 questions a week anonymously from the public, and our psychologist responds to each and every one of them. All questions are hosted on a bulletin board and can be accessed by any user. When Alex feels things are becoming more urgent and he's more in distress and wishes to talk to somebody, he can then call 1771 or access 1771 services through WhatsApp. And we have counselors who are able to talk to him using psychological as an intervention modality. And if Alex feels comfortable to be referred to a professional, 1771 can refer to a network of counseling centers across Singapore. The 1771 service is free of charge, and we run 24 hours a day. Currently, we are handling roughly about 280 calls and messages on any day. We provide emotional support and referrals to general practitioners and counseling centers. If Alex feels that he needs more help, he can come to a psychiatric clinic, and this is available at the Institute of Mental Health. And if he's really in a crisis and an emergency, IMH has the National Emergency Room for Psychiatry based on our campus. And while Alex is waiting for care, because it takes roughly about 2 months, we provide him with apps as well as self-help services on Health Hub as well as the IMH website for him to access self-help tools as well as mental health apps to reduce his mental health symptoms. We have done a preliminary analysis on our AMDTX randomized control trials, and the preliminary analysis shows that AMDTX is able to reduce PHQ-9 and GAD scores for persons on the waitlist. In Singapore, there is a 2-month waiting period to see a specialist in Singapore. So during these 2 months, we provide them this app called AMDTX, which is commercially available on the App Store. However, we have a licensing agreement with Mobio Interactive to provide this app free of charge to our patients during the trial period. Once they enter care, we give them a digital companion in the form of Hope's app. Hope's app provides sleep monitoring, mood monitoring, journaling services, monitors their physical activities, and provides self-help. Paired with a Fitbit app watch, Hope's app is able to send data back with the patient's consent to a hospital dashboard, such that our case managers and counselors can monitor the well-being of our patients. Another intervention that we have done in Singapore is to collaborate with our National Library. When we contacted the National Library and proposed to them to stock mental health apps, mental health books in the National Library, they were more than willing to collaborate with us. And today we have over 130 e-books and audiobooks available in English and Mandarin, available for borrowing from our National Library. Besides organizing all these services, another key component is to market our service. So we actually market our services through buses, bus stops, through the internet, Google Ads, on Meta platforms, as well as on all our subways. In doing so, we want to bring the message out to the public that our services exist, and we have key messages for them to encourage them to call us and to tell them that our services is free and available to them. So the concept in Singapore is that in any tier of severity, Alex should be able to access a service, be it online, in a school, in a community, or when he's ready to come to the hospital for care. And at every tier of severity, we also want to embed a digital intervention to help Alex along on his journey of recovery. Because we firmly believe that no young person should feel alone and suffer in silence, we have come up with our national strategy to bring digital service to young people, because the young person is the demographic who has high distress currently in Singapore. Okay? So currently, Singapore is investing in digital mental health to meet the needs of the population. Singapore residents are using digital interventions, and Tier 2 interventions have over 25,000 users per week. Users access our services through myline.sg, through Let's Talk, and also call us at 1771. So that's the end of my presentation. I hope I've given you an overview of how we provide services to young people in our small nation. Thank you very much.
Thanks, Chris, for that presentation on Singapore. I know that we are very short on time, and therefore I would like us to, as much as possible, do our panel discussion at this point. Let me see if I can reshare the slide of this. Right. Now, I know that there are a number of questions that has appeared on the in the question and Q&A section. Some of them have been answered. There are some open questions, and I'm also aware that everyone has now turned on their videos, the panel. And okay, sorry, I got Prof. Prakash's. So now it's time for some global reflections. I'm going to ask our two experts and chairman of both the International Society of Adolescent Psychiatry and Psychology, Professor Fusun, and Dr. Tony Guerrero, the chair of the World Psychiatric Association Child Adolescent Psychiatry section, to maybe give a few words after that presentation, as well as maybe we will then ask Prof. Prakash to answer some questions that he would like to take off that list of Q&A. So maybe we could start with Fusun and then Tony.
Hi. Actually, Fusun just relayed the message that regrettably she had an emergency and, had to leave the webinar. So I will do my best to fill in. And, I just wanted to say that, it's such a privilege to be in this panel with you all and with Fusun. And, I would encourage anyone to reach out to her if, there are questions that she might be able to specifically answer. But, I just wanted to thank the special presenters today for sharing their incredible wisdom and for the inspiration. I think in this modern world, there are just so many threats that our children are facing from the beginning of the life cycle. And, it's really heartbreaking to see that a lot of the threats that these children are facing are human-made. When we think about the trauma, when we think about the armed conflict, when we think about the degradation to our environment, and when we think about, all of the complexities of modern life that we have introduced, our children are very vulnerable. If you look at global statistics, there are probably, hundreds of thousands or millions of, deaths every year related to things like suicide, violence, accidents that, are the direct results of trauma. And, if we had to translate that into deaths from anything else, this would be like, unleashing pandemics that, kill this many people. And, we have to realize that, the consequences of the traumas that, kids face and that, we may be responsible for, it should really prompt us to, a call for action. And, it's very heartening to see what all the efforts are to better understand all of the risks that our kids face and, the way that these risks may manifest themselves throughout the life cycle and all the ways that we can intervene, from early on. And, I think it gives us hope. I think, the digital future, I think, is very promising as well, and giving us accessible ways to help kids and adolescents and families, on a global scale. We have to think about it this way. The forces that can derail a child's development and that can lead to psychopathology, whether it's, the ubiquitous violence that kids face, whether it's the influences of, substance use and substance trafficking, these forces are just so powerful and so well funded and so well resourced that if we don't have this commitment to staying one step ahead of these, negative influences, if we don't make the commitment to putting in as much resources into, making our treatments as effective as possible and our preventive interventions as effective as possible, then, we will not stand a chance in the future of giving infants, children, and adolescents the best possible future. So, I think these kinds of gatherings, these kind of sessions are so important, to really keep us informed about, how we're understanding kids and, what the state of the science is and, intervening and setting kids on the most positive trajectory possible. So, that was my reflection, in listening to, our very distinguished presenters and, the way that you've all framed, the importance of this special day for infants, children, and adolescents. So, yeah, thank you very much.
Thanks, Tony. Dr. Prakash, do you want to answer any question that's on the list of Q&A?
Yes. I think I put up the guideline, the link to the guideline. Definitely in terms of non-suicidal self-injury and suicidal ideation and deliberate self-harm with the intent to die, there are some children and adolescents who just travel through the journey completely separately to each other, just engage in non-suicidal self-injury without ever kind of having suicidal intent, but that's a very small number. There is actually a significant overlap with the non-suicidal self-injury, definitely increasing the risk of subsequent suicide attempts. So hence in our guideline, we did not attempt to differentiate between the two, and we sort of wanted to cover them both together. I think there was another question briefly about the challenges of engaging young people in care when they have suicidality and self-harm, which is absolutely true. There are multiple reasons why their past experience of being in hospitals, and we are actually undertaking a study where we have learned from the medical experience. So we all know that on the medical side, when children have motor vehicle accidents or admissions to hospital with cancer or other chronic illnesses, and they have repeated procedures, they suffer pediatric medical trauma stress. So we're looking at something similar in the mental health population in our hospital. We're still in the kind of design stages of the study, but we are interested to look at the trauma from hospital admissions, both in the parents as well as in the young people, and the influence of various things that we do, both in the emergency department, but also subsequently in the hospital, and how that influences the attitudes of young people and their willingness to seek help in the future. So that's something we're trying to understand, and it's quite a significant problem. And some basic things like, the layout and the environment, the colors used on the walls of the buildings in the emergency departments and the inpatient services do seem to make a big difference.
Thank you. What about Campbell? Do you have any comments?
Yeah, there's two really good questions from people in the Q&A here. One from a person, Wessel, from a Sudanese background, and asking about the impact of being refugees in a new country and impact on mental health in infancy and early childhood and family. And a really, really important question. Certainly in our community here, we've got a large number of families who've come through various ways, through lots of trauma from Sudan. I guess one of the key things is building and supporting community development and mental health and mental health awareness within communities themselves. And I know there's strong development of resilience within communities here, and some of the young people demonstrating through their sporting prowess, whether it's basketball or running or football, a way for young people to come away from some of the trauma and feel supported despite the trauma that they've experienced in their home country and in adjusting here. And we've certainly seen a number of young mothers and babies, toddlers from the Sudanese community where it's really a big struggle. And again, our job is to support the parents caring for their infant, to hear the baby, what the toddler, what the preschooler have got to say, and validate the parents' capacity to understand their child and take them through some of the trauma and avoid some of the trauma that the parents themselves have experienced. Bettina Bernstein from the States has also asked about the impact of children being taken or moved into out-of-home care. And certainly when you look at ACEs, the adverse childhood events, the circumstances that lead to the removal of a child from families, those children will experience the largest number of traumatic events and at greatest need, and services need to be targeted for those young people. So thanks for your questions.
What about the point about the hope scale? I believe there's a children's version, isn't it?
Well, there's two sort of hope things here. Well, hope's quite an important concept in mental health, and it's been used for a number of different programs. The hope one I mentioned, is from Sherry Madigan in the States. In Canada, and it's an online service for families, and they can. It's free and available. You just register, and there are sort of learning modules for parents who've experienced profound trauma themselves in how to parent their own children to avoid some of those traps, and how to be kind to themselves. I think that's quite an important thing in that program, helping parents to feel and recognise and know that the cycle doesn't have to be repeated, that they've got resources and strengths that they can use to support their child to have a different pathway than they did.
Okay, I'm really sorry about timing. Unfortunately, we really run past the time, and we really ought to end now. And I just want to say a few words as we end. Emotional safety and suicide prevention is of course about frameworks, guidelines, and service pathways, but at the same time, it's about being human. That there is a real person, a real family, a real child, and a real story behind. I am reminded today as I saw a young girl in our clinic. This is an unnatural environment, and she came in with what I thought was a very wide smile. She was cheerful or trying her best to look okay, but behind that smile was the heavy stress of her academic performance. At least in Singapore, that's quite a big thing, and the fear of falling behind. And she really felt that she could not study as she had hoped, and she was somehow less than others. So as I gently conversed with her, we spoke not about just her weaknesses, but about her strengths, her kindness, her courage, her perseverance, and the many gifts that examinations do not measure. I think emotional safety extends beyond healthcare. It is the space where a child can tell the truth behind the smiles, where adults can listen before judging, and that notice before reacting, and stay before walking away. And sometimes this cannot happen in a clinical setting. It cannot happen in a hospital, but it should happen possibly in the safety of a home, of a community, of a school. So let us build systems, but also build warmth. Let us create services, but also create belonging. And let us remember that prevention often begins with presence. So thank you for standing in the minds and hearts of children everywhere as we end today's discussion on the World Infant, Child, Adolescent Mental Health Day. Thank you for coming. We hope that you continue to support the effort And we look forward to seeing you again next year. Thank you very much. Bye-bye.
Thank you very much.